Welcome back. Let's jump in. When a patient is agitated or a scene is heating up, de escalation is your best tool. Here are some proven techniques to help diffuse tension. Stay calm and non confrontational. This is rule number one. Control your own tone and body language. Keep your voice calm, low, and steady, even if the patient is shouting. Avoid the temptation to shout back or argue. Make sure your stance is non threatening. No aggressive postures like hands on hips or pointing fingers. Keep your hands visible and open, arms relaxed at your sides. Your demeanor can either fuel the fire or start to cool it. If you remain composed and respectful, it often helps the patient begin to calm down as well. Also, do not take the bait on insults. If a patient calls you names, it's not about you personally. Responding with anger or sarcasm will only escalate things. Give space and time. When someone is agitated, being crowded by uniforms can amplify their anxiety or anger. If possible, give the patient some physical space. You might take a small step back as long as safety allows, and ensure you're not cornering them. Also, allow time. You don't have to fix the situation in 10 seconds. If they are venting or yelling, let them express some frustration. Again, as long as it's just words and not turning into physical aggression. Sometimes a person just needs to blow off steam, and interrupting or trying to force immediate compliance can make it worse. Maintain a safe distance, ensure you have a clear exit path, but be visibly attentive. If the patient is paranoid, giving space is even more important. They feel less threatened when you're not too close. One rescuer talks. It's easy for an agitated scene to become chaotic with multiple people speaking, which can confuse or overwhelm the patient. Establish, if possible, that one person will be the primary communicator. Usually, this should be the person the patient seems to respond best to or the most senior person. Others should avoid interjecting unless absolutely necessary. This prevents the patient from feeling ganged up on or getting mixed messages. It also helps you build rapport. For example, you might say to your partner quietly, "Let me do the talking," and then to the patient, "Okay, John, I'm the paramedic in charge here. I'm going to talk with you and we'll sort this out together, all right?" Meanwhile, your partner can busy themselves preparing equipment non invasively, etc. This unified, calm approach can reduce confusion and help the patient focus. Validate feelings. A powerful de escalation tool is simply showing empathy. This doesn't mean you agree with any delusions or bad behavior, but you acknowledge the patient's emotional state. For example, say things like, "I can see that you're really angry, frustrated right now. I want to help." Or, "I understand this is scary. I would feel upset too in your shoes." This kind of statement can diffuse tension by making the person feel heard and not judged. Be genuine. Patients often sense patronizing tones. Avoid condescending phrases and don't dismiss their feelings. "There's nothing to be mad about" is not helpful. Also, don't lie. For instance, don't promise we won't take you to the hospital if you know you must. Instead, focus on understanding their concern. "I get that you really don't want to go. Let's talk about that." Validating doesn't magically cure their anger, but it creates a rapport that can start steering them towards cooperation. Offer choices, give control to the patient. A lot of escalation comes from the patient feeling out of control or trapped. Where possible, offer small choices to give them a sense of control. For example, "Would you like to walk to the ambulance or should we bring the stretcher here for you?" Or, "Which one of these family members would you like to come along in the ambulance, if any?" Even minor choices, "Do you want to put on your coat or carry it?" can help. It shifts them from feeling powerless to being an active participant. Of course, only offer choices that are safe and acceptable. Don't give an option that you can't honor, like, "Do you want to go to the hospital or stay home?" If staying home is inappropriate, that would backfire. But whenever there's flexibility, use it to empower the patient. It's amazing how a bit of control can calm someone down. These techniques, used together, can greatly reduce the intensity of a confrontational situation. Remember to also keep yourself safe. If de escalation isn't working and danger is growing, you may need to remove yourself and wait for law enforcement or additional backup. But in many cases, these approaches will prevent the need for force by resolving the patient's agitation verbally. Beyond immediate de escalation, building good communication and rapport with a personality disorder patient can turn a difficult encounter into a manageable one. Here are some tips. Be respectful and professional. This sounds obvious, but under stress, we might sometimes roll our eyes, raise our voice, or say something dismissive. With these patients, respect is crucial. Never mock or belittle what they say, even if it sounds bizarre or overblown. For example, if a histrionic patient says, "I feel like I'm dying," when you know they are medically stable, avoid responding with sarcasm or, "Oh, you're fine." Instead, reassure them you're taking their complaint seriously. Also, avoid phrases like "just calm down" or "you're overreacting." These come across as dismissive. Keep your tone professional and empathetic at all times. If a narcissistic patient is bragging or a paranoid patient is accusing you of nonsense, you might feel annoyed, but do not argue or get defensive. Arguing logic with a deeply held false belief, like a paranoid delusion, isn't effective in the moment. It often entrenches them more. Save the debating for later or for psych professionals. Your priority is to safely assess and transport. Use simple, clear language. Under stress or due to mistrust, patients with a personality disorder may not process information well. Avoid clinical jargon or complex explanations. Explain what you're doing in plain terms and why you are doing it. For example, instead of "we need to establish IV access to administer isotonic fluids," say "I'm going to start an IV. That's a small needle in your arm to give you fluids or medication if you need it. This will help if you start feeling worse." Clarity helps build trust. If the patient is paranoid or anxious, knowing what's happening can reduce fear of the unknown. Also, speak in short, clear sentences, especially if they're very upset, so they can follow along. Check in for understanding if they seem confused. Sometimes asking them to repeat back or just asking "okay" can ensure they're on the same page. Set gentle boundaries. While we empathize and give some control, we also need to maintain order and safety. It's perfectly okay, in fact necessary, to set limits in a calm, gentle way. For instance, if a patient is shouting and not letting you proceed with an assessment, you might say, "I understand you're angry. I want to help you and I will listen to you. But I need you to stay seated and not swing your arms so I can check your blood pressure safely. Is that okay?" This kind of statement acknowledges them, but also clearly states what you need from them. Boundaries could include things like not allowing verbal abuse. "I want to help, but I can't continue if you call me names like that," said in a calm tone, or physical limits. "Please keep your seatbelt on. I don't want you to get hurt if we stop short." Offering a reason for their benefit or safety helps compliance. If they violate a boundary, try to calmly restate it and the consequence. For example, "If you try to hit us, we will have to restrain you, and I really don't want to do that. Let's work together here." Always follow through if safety is truly at risk. Boundaries actually make patients feel safer too, because it shows someone is calmly in control of the situation. Don't take it personally. This is huge for EMS providers' mental state. A patient with a personality disorder might hurl insults, make unreasonable demands, or cry hysterically that you're the worst medic ever, often triggering our own emotions. It's human to feel hurt or angry, but remind yourself, this is the disorder talking. The patient likely behaves like this with many people in their life. It's not really about you. They might even later apologize or have no memory of how extreme they got. If you can depersonalize their outbursts, you'll maintain your own calm much better. Think of it as a symptom, like how you wouldn't take it personally if a diabetic patient in hypoglycemia was combative. Similarly, an emotionally dysregulated patient might lash out due to their condition. This mindset helps you stay in the role of the professional helper rather than getting caught in a personal confrontation. Team consistency. Make sure you and your partner or other responders present a unified approach. If one of you is setting boundaries and the other is bending the rules, the patient will notice and may exploit that, not even consciously. It's just how some have learned to interact. For example, if a patient says, "The other medic lets me smoke a cigarette before going, why won't you?" And that's not allowed. Both of you need to be on the same side. "I'm sorry, none of us can allow that. Those are the rules." Avoid playing into a good cop, bad cop dynamic. If you notice the patient splitting, "she's nicer than you are," don't get defensive. You and your team member can even explicitly acknowledge each other's efforts. "My partner is trying to help you too. We both care about getting you safe help." Consistency builds trust and closes loopholes for manipulation. By communicating clearly, respectfully, and consistently, you will make the patient feel more secure and you'll retain control of the scene. It's not always easy. These situations test our patience and empathy, but using these strategies will improve outcomes and scene safety. One of the most important aspects of caring for patients with personality disorders is maintaining compassion and professionalism. This not only benefits the patient, but also upholds our ethics and keeps the care patient-centered. Let's break this down. Show empathy. We touched on validating feelings. Empathy goes hand in hand. It's crucial to remember that whatever the patient is feeling is very real to them, even if it seems irrational to us. For example, a paranoid patient's fear or a borderline patient's despair is their reality in that moment. By actively listening, making eye contact, nodding, using phrases like, "I understand this is hard for you," we convey that we care. Sometimes spending an extra minute just listening to a patient's rant or worries, when medically appropriate, can build enough rapport that they become more cooperative. Compassion can de escalate where commands fail. Also, small gestures matter. Offering a tissue to someone crying or covering a patient who is feeling exposed demonstrates empathy nonverbally. Avoid stigma and labels. In the heat of a difficult call, one might think or even say things like, "Oh, this guy is just crazy," or "She's a psych case, just attention seeking." It's critical we avoid derogatory labels. Not only could patients overhear, damaging trust completely, but it also biases our care. If we dismiss someone as just attention seeking, we might miss a real medical issue or undertreat their pain. In training, you'll hear the term frequent flyer. Try not to let that term make you cynical. Yes, some patients call often for non emergencies, but each encounter should still be approached seriously and respectfully. When documenting or handing off, use respectful language. Say, the patient has a history of multiple EMS calls and appears to have chronic emotional needs, rather than, she's just a borderline personality, nothing really wrong. Stick to describing behavior factually without insulting terms. Also, remember they have an illness. Just as we wouldn't scorn a diabetic for having high blood sugar, we should not scorn a personality disorder patient for their behavior. Stay patient centric. Even when a patient's behavior is challenging, we must keep our focus on meeting their needs, both medical and, to a reasonable extent, emotional. Ask yourself, what does this patient need right now? It might be medical intervention, e.g., suturing those cuts or calming meds for severe anxiety, and psychological support, reassurance, not leaving them alone, etc. By keeping a patient centered approach, we remind ourselves that we're there to help a fellow human in distress, not just to deal with a problem. This mindset can guide our actions. For instance, if a patient is yelling because they're scared, their need might be information and comfort, not just a quick transport. So you slow down and address that fear if you can. Professionalism means not getting caught up in any provocations and always acting in the patient's best interest. Self care for providers. Lastly, acknowledge that these calls can be emotionally draining or frustrating for us as providers. It's okay to feel that way. We're human too. After a tough encounter with a personality disorder patient, it's helpful to take a moment with your partner to debrief. This can be a quick chat. Wow, that was rough. I felt like nothing we did was right for her. You can vent to each other after the call, away from the patient, support each other. These situations can cause stress or even self doubt. Did I handle that okay? Talking it through and possibly having a laugh about the absurd moments in private is a healthy way to cope. If a particular patient frequently gets under your skin, discuss strategies with colleagues or supervisors. And remember not to carry that frustration to the next call. Each patient deserves a fresh start. Some EMS systems also offer formal debriefings or counseling if you have a particularly traumatic or difficult patient encounter. Taking care of your own mental well being will keep you effective and empathetic on the job. In summary, maintaining compassion doesn't mean you allow bad behavior to go unchecked. It means you approach it with understanding and professionalism. This benefits the patient by giving them the best care possible, and it benefits you by creating a more positive interaction, or at least preventing a negative one from worsening. We're in the business of helping people, and that includes the ones who are hard to help. Proper documentation is essential whenever you handle a call involving abnormal behaviors or potential personality disorder issues. It protects you legally, helps continuity of care, and creates a record in case this patient is a repeat caller. Here's what to focus on. Document objectively. Chart the patient's behavior and statements objectively and in detail. Use direct quotes for important statements, especially anything involving threats, suicidal ideation, or refusals. For example, write patient stated, "I want to kill myself," while holding a piece of glass to forearm. Or patient yelled, "If you come near me, I'll knock you out." These exact words are powerful and clear. Avoid inserting your personal opinions or diagnoses. Don't write patient was acting crazy or likely borderline personality. Instead, describe what you saw and heard. Note the time sequence if relevant, like initially cooperative, then at 14:20 became combative without obvious provocation. Objective documentation is crucial if later there are any questions about the care or if the case has legal implications. Note interventions and outcomes. Document all the actions you took to manage the situation. If you employed verbal de escalation, you can note something like utilized verbal de escalation, spoke calmly, offered patient choices, and allowed space. Patient gradually became more cooperative. If things escalated to requiring restraints or sedation, document the justification and process. Patient continued to attempt to hit crew, so soft restraints applied to wrists and ankles at 14:25 with police assistance. 5 mg midazolam IM given per protocol for severe agitation. Also note how the patient responded to interventions. Patient calmed and no longer combative after restraint, or continued to yell but could not harm self or others. This documentation shows that you tried less restrictive measures first, if applicable, and that any use of force was a last resort for safety, important for legal review. It also helps the hospital know what worked or what was done pre-hospital. Include mental status. In psychiatric or behavioral situations, always document the patient's mental status and decision-making capacity. For example, note orientation, alert and oriented or confused, mood, appeared anxious, and insight. Patient does not acknowledge need for care. If the patient refuses care or transport, this is absolutely critical. You must document that you assessed their capacity to refuse. That might include no signs of confusion or intoxication, or if there are, then they may not have capacity. Patient able to repeat back risks of refusal, etc. Document that you explain the risks of refusing and what those risks were, and the patient's response. For instance, explain to patient that refusing transport could result in worsening of condition or death. Patient states understanding and still refuses. Also have them sign an AMA against medical advice form if that's procedure, and note if they refuse to sign that too. If law enforcement or medical control was involved in a decision, like to not allow refusal due to mental health hold, include that as well. These details are your legal protection if later the patient alleges something or if questions arise about why they weren't transported. Handoff information. When you transfer care to the hospital or another provider, verbally communicate important aspects of the patient's behavior and what worked. For example, quietly inform the receiving nurse or doc, "This patient threatened to hurt staff en route but calmed down when we spoke softly and let his wife stay with him." Or, "Patient has borderline personality disorder per her history, cut her wrists after an argument, very fearful of being left alone. We kept reassurance constant." By doing so, you help the next team continue effective strategies and be prepared for any repeat of aggression or self harm. Also, mention any safety concerns. If the patient tried to grab your scissors, if they talked about wanting to run away, the hospital security can then be on alert. Document in your report that you gave this handoff information as well. ED staff briefed on patient's threats to self, recommendation for one-to-one observation given. Remember, documentation should paint a clear picture of the call. If in 6 months you're asked to recall this event or in court a year later, a good report will be your memory. With behavioral calls, more detail is better. You're justified in writing a longer narrative here. Ensure it's factual and free of derogatory language. In the long run, thorough documentation and proper handoff can also contribute to these patients getting the consistent care and follow up they need, like flagging to psych services that this person has frequent crises. In conclusion, dealing with personality disorders in the EMS setting is challenging but manageable with the right approach. Let's recap a few key points. Big picture. Remember that as an EMS professional, you are not there to diagnose or cure the personality disorder. These conditions are long standing and won't be resolved in a single interaction. Your goal is to address the immediate crisis or medical need while navigating the personality driven behaviors. That means sometimes the win is just getting the patient safely to the hospital or gaining enough trust that they accept care. Don't get discouraged by the fact that you can't fix their lifelong issues on scene. Do what you can, ensure they're medically stable, not a danger to themselves or others during your care, and get them to the next phase of help: ER, psych evaluation, etc. Stay calm, stay safe. You've seen how much your own demeanor and tactics can influence the situation. By staying calm, using de escalation, and watching for red flags, you greatly increase scene safety for everyone. Conversely, if we react with anger or impatience, things can spiral. So, whenever you sense a personality issue at play, take that mental step back and employ the communication and de escalation tools we discussed. Your safety and the patient's safety are the top priorities. If you keep those in focus, you'll navigate even the wild swings of a borderline crisis or the intimidation of an antisocial patient much more effectively. Treat the person, not just the behavior. This is a reminder to maintain empathy. Behind every outburst or manipulative ploy is a person in distress or with a difficult life history. Many personality disorder patients have histories of trauma or abandonment. That doesn't excuse bad behavior, but it does remind us that compassion is warranted. Even if you must be firm, like during restraint or boundary setting, you can still be kind. For example, speaking gently to a restrained patient and telling them you'll make sure they're okay is treating them as a person, not just a problem. Little acts of kindness, addressing them by name, assuring them you want to help, not giving up on them even if they're challenging, can leave a positive impact. You might be one of the few people that day who treated them with dignity. That matters. Know your limits. Get help if needed. Finally, recognize when you need backup. Some situations will overwhelm even the best communicators. If a scene is unsafe, do not hesitate to call law enforcement early. If a patient is too much to handle emotionally or you're unsure of the best approach, consider requesting a supervisor or a colleague with mental health expertise. Some systems have specialized response teams. Use medical control. Online medical direction if you need advice or orders for chemical sedation, for example. There's no shame in asking for help. It's better than trying to tough it out and risking injury or an ineffective outcome. Also, post call, if an encounter really bothered you, reach out to peers, mentors, or mental health resources. Your well being is important too. By keeping these takeaways in mind, you'll be better prepared for the next time you encounter a patient with a personality disorder. Each experience will also build your confidence and skill. Join me in the next section to apply what we have learned to possible patients you may see in the field.